So I would like to start this presentation by this real-life clinical scenario that I'm sure many of you will identify with. So this is Lisa, a 33-year-old female, very active, with no spinal concern, who had just got married and she's planning her family life. So she came to our outpatient clinic with these x-rays and with one very powerful question: when should I get my surgery done? So as you know, Lisa's question represents one of the most challenging issues in treating thoracolumbar curves in the adult age. So on one hand, surgery in her age would mimic that of adolescence, allowing us to stop at L3. However, delaying surgery would gradually increase her chances of having a pelvic fixation, increasing surgical morbidity, chances of having a complication, and decreasing surgical gains. So to answer her question, we must embark on the search for this mythical waterfall that is marked by an age-related inflection point where pelvic fixation abruptly becomes a necessity. So it shifts from being unlikely to becoming mandatory. So we conducted a retrospective analysis of prospective database, included all patients having a thoracolumbar curve superior to 45 degrees and having surgery in the adulthood. We followed them up for at least 2 years, and we excluded patients that did have prior surgery or had a non-idiopathic curve. So we had 240 patients meeting the study criteria. Mean age was 52, 48% of which had pelvic fixation at initial surgery, and a further 3% needed pelvic extension at an average of 3.8 years. So as expected, patients needing pelvic fixation were on average 20 years older and had a higher BMI. Surgery was also more invasive, 50% longer, 2 to 3% more blood loss, 3 levels more of fusion, and more importantly, it increased surgical complication by 3 to 9 folds. Prior to surgery, both groups had similar coronal alignment, both in the main curve and the lumbosacral curve. Patients needing pelvic fixation had worse sagittal alignment, both in gap scores and in absolute numbers. After surgery, we had a comparable correction of the main curve, and surprisingly, we had a spontaneous normalization of the non-operated lumbosacral curve, both in the coronal and the sagittal alignment. We did improve sagittal alignment, however, it was still worse in the patients needing pelvic extension. So, binary regression model identified both age and sagittal balance in the form of RSA as independent risk factors for needing pelvic fixation. Also, we confirmed collinearity between both factors. And to show you the importance of age, a 55-year-old person had 10 times higher probability of needing pelvic fixation than a 25-year-old. And the 75-year-old person had 46 times that chance. So the optimal cutoff for age and RSA were 53 and 20-year-old, and 20 degrees. And the area under the curve was 0.85, which was pretty high. With these cutoff values, age was very sensitive in detecting patients needing pelvic fixation, whereas RSA was very specific. Combining both risk factors into a linear score, we had an almost perfect relationship, with patients having none of these risk factors, only needing pelvic fixation in 9% of the cases, whereas patients having both needing it in 91% of the cases. This scatter plot shows why age is so decisive. Patients with younger than 53 were most of them well aligned, and the ones that were not were actually a small minority. And in this group, we would be right 91% of the cases if we do not fix them to pelvis, and we'll only regret it in 2% of the cases. Whereas if patients are older than 53 and they have an RSA above 20, we would be right 91% of the times when we do fix them to pelvis, and we regret it only 14% of the times. There remains this group where only 40% would need a pelvic fixation, and this is where research should go. So in summary, we did find this waterfall represented here by this Kaplan-Meier surgical survival without pelvic fixation, where patient navigated rather smoothly up till the age of 40 when something happens, and if they do not get their surgery done, they do reach a non-return point at the age of 53 with a sharp increase in their needs of pelvic fixation that only stabilize at the age of 80. So the remaining question is whether treating Lisa at this early age, which actually alter the natural progression of the lumbosacral curve, therefore making her needing pelvic fixation unlikely in the long term. Thank you very much.